Sure. I'm a assistant professor of medicine here at Columbia University Medical Center. I'm the clinical director of the Thoracic Medical Oncology Group, and I am a lung cancer doctor and a lung cancer researcher, and I love what I do. Well, I had heard about this drug. We actually started with this drug very early on, and I just thought the science behind it was really interesting. It's a bispecific antibody targeting EGFR and MET, and it's a really important pathway, the EGFR mutation in particular, but then also a lot of the acquired resistance pathways are through MET. So I thought that this would be a great drug. And so we actually had signed up to conduct the study, actually the Chrysalis study from the very beginning. And then as we continued on, seeing some great responses, we also signed on to do Chrysalis 2. So Chrysalis 2 combines amivantamab, which is that EGFR MET bispecific antibody, with lazertinib, which is a third generation tyrosine kinase inhibitor. And it combines the two. In the Chrysalis 2 study that was presented at ESMO, we were looking at the post-osimertinib, post-platinum population. So these were patients who had progressed on osimertinib and then on chemotherapy. And right now, there really isn't any good treatment regimen for them after they've progressed on those prior therapies. So this is kind of an unmet need. And what we did was we looked at the endpoints were overall response rate, but we also looked at things like duration of response, clinical benefit rate, progression-free survival, and then importantly, the safety profile, which is the adverse events. And in the target population, which is kind of the post-platinum, post-osimertinib population, we saw that there was a response rate of 41%. The clinical benefit rate was 69%, so that also includes people with disease stability. We saw responses very early, so some people were responding in, at 1.5 months at that first scan. And out of 12 patients who responded, 8 of them continue to be progression-free and remain on treatment. So it's, it's a great great numerically, and also great to see in clinic when people have their disease shrink. Just in terms of safety, which is another really important part of the study, we found that the combination of the two drugs was well tolerated. The main issues tend to be things that are kind of EGFR related, which rash, paronychia, stomatitis, and so mouth sores. But in general, well tolerated. And I would say the most important thing that everyone's asking about with amivantamab is this idea of the infusion-related reaction, which we saw first with Chrysalis, and we also see with Chrysalis 2. But the drug can cause an infusion-related reaction, which is typically on the first day of infusion. So on that cycle 1, day 1, patients, might experience an infusion reaction, which can be like increased blood pressure, flushing, some chest pain, some shortness of breath. And it's typically within the first few minutes of the infusion. We stop the infusion, we slow down the rate, we give them additional medications, and then most people are able to get through it. And we've really learned a lot about the infusion reaction since the first days, and we give people pre-medications. We really know how to manage it, and then most people never have that infusion-related reaction again after the first day. So I think that's an important thing for physicians and for patients to know. The study is still, it's a small population, especially in the kind of that target population that we were looking at. So we're interested in seeing as the study continues on, and just gather more patients. There are a couple other cohorts of interest in Chrysalis 2. There is an exon 20 insertion cohort. Amivantamab is now FDA approved for exon 20, but as a monotherapy, and we're trying to see if we add in lazertinib, if that's going to make a difference. There's a cohort for atypical mutations. That's another kind of unmet need that we're still trying to figure out. And there's a cohort that's for like post-osimertinib biomarker validation to see, what types of acquired resistance mutations might be the most relevant for this type of drug. And then I would say the other important thing about, limitations or, other added benefits of this drug is really to figure out the CNS penetration. That's a really important thing. A lot of these patients have brain disease, and the reason that lazertinib is particularly exciting to me as a addition to amivantamab is that lazertinib has known brain penetration similar to the way osimertinib does. So, does adding lazertinib in improve that CNS penetration? And I think that'll be kind of an important question to ask. Yeah, I think it has a lot of clinical implications because, like I said, this wasn't like an area that this is kind of an unmet need. So if we're able to show that post-osimertinib, post-platinum-based chemotherapy, this is the next line, like I think that that's huge because these patients really, they often do live for a longer period of time and they need other treatments after those initial ones. So I think that this could really slide nicely into kind of the whole paradigm of treating EGFR mutations. And actually, interestingly, there's another trial called Mariposa that is looking at this combination in the first line against osimertinib. So, is this going to be a first line regimen? Is this going to be a second line regimen? Is this going to be a third line regimen? I think all of those questions are still unanswered and are interesting. Well, I would say that I just had a patient I put on to single agent amivantamab for an exon 20 insertion, and she had this giant chest wall mass. And on day one of the infusion, she said she immediately felt better. She felt like it was softening. And I was like, like day one, it seems a little bit of, maybe a tall tale. And but the infusion is given weekly, so I see her every week. And by that third week, I can't even tell you the mass, the chest wall mass has like completely shrunken down, and her chest wall is like flat now. So it's the drug definitely works. It clearly works, and I think we're all excited as investigators to have been able to work on it. But really, I think the question is going to be what situation is it best in, what drugs in combination is it best in, and how do we kind of maximize the benefit for the most number of patients?